I'm Ramaswamy Govindan, a medical oncologist at Washington University School of Medicine. We'll go ahead and introduce other panelists here, Dr. Lanuti.
Yes, hi, Michael Lanuti. I'm a thoracic surgeon at the Massachusetts General Hospital in Boston and the director of thoracic oncology for our division.
My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis.
I'm Sanjeev Bala. I'm the head of cardiothoracic imaging here at WashU in St. Louis.
I'm Dr. Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine.
Patient with small cell lung cancer. This is a 60-year-old female reformed smoker, 45-pack history of tobacco smoking with multiple comorbidities, presence with limited stage small cell lung cancer involving the left mainstem bronchus and mediastinum. And we'll discuss the management in a minute. This patient presented with progressive shortness of breath and non-productive cough over 2 months with new wheezing on exertion, performance status of 1, and with the medical history significant for chronic kidney disease, type 2 diabetes, history of stroke in 2016, asthma, and hypertension. A social history is significant for 45-pack history of tobacco smoking. Family history is not known. Let's review the CT image. Dr. Bala.
So we have two sets of images. We have the non-contrast CT followed by the PET CT. On the non-contrast CT, the upper image demonstrates her mass, which is a 4.4 by 5 centimeter infiltrative mass surrounding the left main bronchus. The lower image is to show that there's a 1.7 centimeter right paratracheal lymph node. And all of these findings are confirmed on the PET scan, where we can see that there's uptake of FDG in the central mass as well as in the right paratracheal lymph node.
Thank you. So this patient undergoes EBUS endobronchial ultrasound-guided biopsy of the right lower paratracheal node and left hilar mass. Findings are consistent with small cell carcinoma, positive for CAM5.2, TTF1, synaptophysin, and CD56, and negative for chromogranin and LCA. And brain MRI and CT of the abdomen and pelvis were negative for metastatic disease. So this patient has a limited stage small cell lung cancer traditionally. And this patient started with carboplatin etoposide because of kidney failure and received 1 cycle of chemotherapy with improvement in the symptom, and then had ended up completing 45 gray in 30 fractions, twice daily fractions to the left hilum and mediastinum with concurrent carboplatin etoposide, predictably developed neutropenia and cellulitis, given the myelosuppression associated with carboplatin, and also had esophagitis and 30-pound weight loss. A follow-up CT scan showed significant decrease with some residual disease. MRI of the brain continues to be negative, and the patient declines prophylactic renal radiation. And this patient goes on to develop a new right upper paratracheal node months later, and a biopsy was consistent with small ones and had palliative radiation therapy to the right upper lobe. And now, well past a year, has no evidence of recurrent disease. So the questions here is, what should be the upfront strategy? When you have this recurrence, especially the localized one, how would you manage this patient? And there are lots of things to talk about here. And the one thing we don't have much to talk about, we can probably touch on that briefly, is the role of surgery and move on to discuss chemotherapy, radiation, where the field is going, once, twice a day radiation, prophylactic renal dose, the dose of thoracic radiation, the choice of chemotherapy agents. There are a number of things we can talk about. So we'll spend about 10 minutes discussing these things. And before we really go into the depths of the discussion, maybe Dr. Lanuti can comment on, when is surgery appropriate for small cell?
Yeah. So small cell can come in two scenarios for us. One is that it's an unexpected finding after a pulmonary resection of a growing nodule that was perhaps node negative clinically. And then if you did know that there was a small cell lung cancer, then really for us, the patients that are highly selected, that is patients that have node negative disease, would be very amenable to an anatomic resection, oftentimes lobectomy. So the important part of that is to, one, do invasive mediastinal staging prior to considering a pulmonary resection in a known small cell. It'd have to be something that you could completely resect. And once it is performed and you are node negative, we often rely on adjuvant chemotherapy. And then people talk about, the role of PCI. But I think for us, it really is small peripheral disease that's node negative.
Yeah, that's we see that maybe once or twice a year, I think, at least in our practice. Not very common. And so the bulk of the discussion is going to be around radiation, I would think, to begin with. Dr. Robinson, your thoughts on how would you have managed upfront, and then and maybe we'll stick to that first, and then we'll come back to the recurrence.
Of course, yeah. As you mentioned, I think there's a lot of evolving questions for these patients. The first, if we stick to the definitive management of the tumor itself, there are a variety of acceptable radiation dose and fractionations for small cell in 2021. Certainly 45 gray at 1.5 gray BID is a classical Teresi regimen. That's a randomized trial comparing that to once daily, albeit at a lower dose. The outcomes are the same for twice versus once daily for that dose at 45 gray. Unsurprisingly, the patient experienced severe esophagitis. That's the number one side effect with twice daily radiation. The theoretical appeal to twice daily radiation is because of kind of core, fundamental, basic radiobiology principles of these rapidly growing and rapidly proliferating tumors where we worry about accelerated repopulation. So twice daily radiation has that theoretical benefit. However, it has now since been compared to once daily at a higher dose, where we gave over 60 gray compared to 45 BID, and there was no significant difference between those two different dose and fractionations. So at this point, one could very easily give once or twice a day with available data. As it relates to the subsequent consideration of PCI, that again it also remains highly controversial. We have pretty compelling data from a couple decades ago that in populations not undergoing routine MRI brain surveillance, that the addition of PCI in good responders had a small but significant improvement in overall survival and definitely decreased the rates of neurologic death in these patients. Now that we do more routine brain surveillance, it's unclear whether that is the right approach. This is now being re-asked again in modern times with MRI through the Maverick trial and others that are randomizing patients to PCI versus surveillance, not unlike what has been done in the extensive stage population already.
I have a question for you. What is your preference? Once a day, twice a day? Imagine the patient comes and tells you, you're the doctor, I'll do whatever you say. How do you steer the discussion?
Yeah, I think that at this point, there is a tremendous value in trying to accelerate and complete the radiation portion as quickly as possible. This is overall managed by chemotherapy. The radiation is an important component to their treatment. But at the end of the day, it's most important, I think, that the patient be able to complete their entire course of chemotherapy as well. And we want to make sure that we're a key contributing party to not preventing that. And then, as I mentioned, for the biology aspect, there's an appeal to more accelerated treatment as well. It's hard for me right now, in the absence of a patient perhaps just having some logistical issues with coming in twice a day, which is no small feat for patients to come from a distance. Generally, we would prefer twice a daily radiation as our standard. We offer once a day radiation for those patients for where coming in twice a day would be implausible, generally.
Is that the national standard now, Dr. Robinson? Would you say twice a day radiation is more common than once a day in the US practice pattern surveys of radiation oncologists?
No, it is not. So despite the evidence, the more kind of routinely used regimens have been once a day for some time now because of those logistical issues in large part. There may be other issues that play into that as well. There is some interesting data that just came out recently, which is difficult to quite wrap our heads around, where they've given twice a day radiation and they randomized to 45 versus a higher dose of radiation also given twice a day. And it's a small randomized trial that was just published that suggested improved outcomes. So we're keeping our eyes on that to see if there's some potential benefit to dose escalation.
Sadly, our experiment with dose escalation did not work well for non-small cell, but it's a different dose level, different disease, so we won't extrapolate that. Dr. Levy, what are your comments on the choice of chemotherapy, and what cautionary note you would sound for practitioners when they use carboplatin concurrent with thoracic radiation?
I think yeah, a very good question. I think we saw this here with the cytopenias that this patient developed. Unfortunately for this patient who has chronic kidney disease, type 2 diabetes, a history of stroke, has a lot of comorbidities that may preclude the use of cisplatin in this case. So I think I agree with potentially using carboplatin, given the fact that this patient did have chronic kidney disease. We don't know what the creatinine clearance is, but I would default to carboplatin. However, when using carboplatin with etoposide, carboplatin is given day 1, etoposide given day 1, 2, and 3. We do run into issues with cytopenias that can be challenging, especially when giving radiation at the same time. And just a little nugget here, we really don't encourage growth factor support in this case. When they're getting concurrent chemoradiation, even if you see these cytopenias, we really can't give growth factor support. We try to just delay the treatment. Carboplatin, however, is not a bad word. There has been data published to suggest that carboplatin etoposide may be as good as cisplatin etoposide in limited stage small cell. I think we certainly have the data in extensive stage, but even in limited stage. That said, for limited stage small cell, I will make every effort to try to give cisplatin with etoposide concurrently with radiation.
Thank you. In fact, I highlight that point often when I give lectures, when I talk to practitioners, that routine use of prophylactic growth factors is not a good idea. I also use a lower dose of etoposide. There's a range, 80 to 120 milligram. And my former mentor, Dan Idy, did some of those studies. And I think 80 milligram per meter square of etoposide, I think it's just as good as a more myelosuppressive 120 milligram per meter square given on day 1 to 3. I think it's important. So I stay on the 80 milligram side and carbo EUC of 5 or cut down the dose to 4 with the next cycle if necessary, and then avoid growth factors. So that's an important point I want to highlight. Yeah, in the interest of time, we'll be brief in that second part of the discussion. This seemed like a recurrence, local recurrence. Dr. Robinson, do you want to comment on that? What could have been possible and how would you have treated? And then very briefly, we'll get Dr. Levy's thoughts on his systemic chemotherapy here.
Yeah, this is always a challenging question in small cell where the predominant pattern of failure is typically distant. For those occasional patients that appear to have isolated regional failure, I do think that there is appeal to considering, just like we would in patients with non-small cell, to deliver a more definitive salvage strategy. The timing of this is that it was almost a year since the completion of their last radiation. So whether you believe that there's an absolute cutoff at a year for platinum insensitivity or not, I suppose is up for some debate. But from a patterns of failure standpoint, this patient's done well. So I would, while I say that it may not be unreasonable to consider an induction dose or 2 of chemo to confirm that there's no additional systemic progression and that there's some sensitivity here, I would at least give some consideration to a more definitive salvage dose of radiation rather than palliative radiation for this patient.
Thank you. Dr. Levy?
Yeah, whether we use a year or 6 months as, platinum sensitive versus refractory, some would argue that even 6 months of the last treatment could be re-challenged with platinum. So, unfortunately, as you know, Dr. Govindan, we don't have a lot of systemic options for these patients. And we're still trying to iron out some of the genetic underpinnings and personalizing therapy for small cell. And we're not there yet. And hopefully in the next 5 years, we will be. This is a patient that I'm not comfortable with the regimen that was used here, the carboplatin paclitaxel. That's more of a non-small cell lung cancer regimen. I would re-challenge this patient potentially with carboplatin etoposide with radiation. You made a good point about being nuanced with the dose. Maybe that next go around, the patient's marrow may not be well preserved. I may go down on the dose AUC of 4, etoposide 80 rather than 100, which is the dose I usually use for treatment naive patients. But we're still going for cure here, and that the data that we have is that patients generally, if it's more than 6 months, to consider rechallenging with platinum etoposide. That's what I would do in this case.
I know, thank you. I know, Dr. Robinson, you don't have that radiation therapy field records here to say whether it's an in-field or out-of-field recurrence. To me, it seems like it's very hypothetical. It seems like that this patient would have done just as well with radiation. What really controlled is the local recurrence that was managed with radiation. So you could argue about this. You'll never know the answer to that. Is it really necessary to give chemotherapy? If you feel compelled to give chemotherapy, I agree with Dr. Levy. I would have given the same chemotherapy regimen. I just wanted to know whether you have any closing thoughts on that.
Yeah, I think that's reasonable. The general teaching being that it's a systemic disease is hard to shake. With that being said, when someone has declared themselves and had a full year to disseminate widely, and they haven't, perhaps that disease is showing us that it is staying more regionally, failing. So I think radiation alone is certainly a reasonable consideration. And then moreover, to the notion of infield versus out of field, that is important. In this case, I presume that it was more out of field because we do not generally treat elective nodes anymore. So the prior nodal disease looked to be a little bit low to that. However, if it had received full dose radiation, then that does play into the risk-benefit ratio for additional radiation for this patient.
Thank you. Thank you. Thank you so much for a wonderful discussion with this very common problem.